Good afternoon, everybody, and thank you for joining us today to our third NLAAD webinar um, from 2024. NLAAD has been our national campaign for awareness on Latino community since 2003. So this is the 21st year that we're doing this, and we still continue doing this because we think there is still a need to educate and inform our community about the resources that we have available these days to end the HIV epidemic. There is so much to do still, and despite the advances of the science and medicine in this field, we still haven't got to the point where we can say that we have ended this epidemic. But we have testing, we have prep, we have prevention techniques, and we also have a treatment, which is going to be taken care today by Dr. Alice Roque Garner from Emory University. She kindly accepted to do this webinar for us, and we will continue with NLAAD for as much as we can. We need to do this. As I mentioned, this year we are focusing on treatment because we think treatment is very important in the pillars during this epidemic. Last year we were more focused on prevention, but we'll continue doing more webinars on information about HIV and the resources we have available. So today, my name is Luis Mares. I'm sorry. I'm the Director of Community Mobilization Programs at the Latino Commission on AIDS in New York City. And we've been running this, as I told you, since 2003. This year, you might have received an email with the posters that we have this year about the campaign. These are a series of 5 posters that we have posted also in our website, nlaad.org. You can go there and download them from our website directly, and you can print them and use them for your campaigns, your events. Before we start, did you know this meeting is being recorded, and you have noticed that when you log in, you were muted automatically. Please formulate your questions for Dr. Roque Corner in the Q&A box. And at the end of the webinar, you will receive a survey will pop up your screen so you can reply to us about your opinions, your comments, and your advices on the webinars that we are doing. Then Dr. Alice Roque Garner, she's going to do the presentation today about advances in HIV treatment. So, Doctor, the floor is yours.
Thank you, Luis. Let me go ahead and share my screen really quick. Okay, I'm just confirming that you guys see the screen and not the presenter view.
Yes.
Sounds good? Okay. And can you hear me okay, Luis?
Perfect.
Okay. So thank you so much for having me today. My name is Anneli Roque, and I am currently, as Luis said, an assistant professor in the Department of Medicine, Division of Infectious Diseases at Emory University in Atlanta, Georgia. I'm actually primarily based out of Emory University Hospital Midtown, which is one of the 4 Emory-associated hospitals in our city. So it's an absolute pleasure to be here with you today to talk about a topic that is near and dear to my heart as a Cuban immigrant and a Latinx physician. Today, we're going to discuss HIV in the Latinx community from a clinician's perspective. So I have no conflicts of interest to disclose, but I will use trade names back and forth in this talk, and I swear I get no money from drug companies. So our roadmap from today is going to be, first, we're going to be speaking about the state of HIV in the Latinx community, just kind of on a United States level, on a larger scale. Then we're going to talk about barriers to care for our community. Then we're going to go into a little bit of treatment 101, where we're going to talk about first-line treatments and some of the newer treatments that have come out. And then we're going to talk about treatment options in general for newly diagnosed folks and folks that are re-engaging in care. And then we're going to talk about next steps as we close. So let's start by setting the stage for where we are as a country, with the caveat that the latest data that we actually have nationally on HIV diagnoses is from 2022. This is not unusual. There's generally a lag in when we get data, and that lag is usually between 1 and 2 years as data gets analyzed and then gets reported on a national level. The data that we have now from 2022 gives us a glimpse of the effects of the pandemic on HIV diagnoses, but it doesn't give us the entire picture because obviously it only extends to 2022. There were close to 38,000 new HIV diagnoses in the United States in 2022, and nearly a third of those were in Hispanic or Latinx folks, which ongoing I'll refer to as just Latinx for ease. This disparity in new HIV diagnoses is deeply felt in Black and Latinx communities and is the result of a complex interplay of racism, HIV stigma, discrimination, poverty, barriers to healthcare, and much more, which we will touch on in this talk. Now, if the last slide wasn't concerning enough, these two graphics truly highlight why HIV clinicians like myself who take care of Latinx folks living with HIV are actually truly worried about what the next data is going to look like, the data for 2023, the data for 2024. From 2018 to 2022, HIV diagnoses increased by 17% in the Latinx community. And as of 2022, only 84 out of 100 persons with HIV in the Latinx community knew their status. Both of these data points are significant because they signal that there is ongoing high levels of transmission within the Latinx community and a concern that new diagnoses will only continue to rise. Let's dive deeper on a state level. Obviously, I can't go through too many states, but we're going to go through my adopted home state of Georgia, where I've lived over the last 3 years. Previous to that, I was in San Francisco in California, which is a whole different situation than here in the Southeast. So the Southeast as a region of the country accounted for 52% of all HIV diagnoses in 2022 per the CDC. According to the Georgia Department of Public Health, Georgia was second nationally in the rate of new HIV diagnoses amongst adults and adolescents after the District of Columbia during the same time. And when looking at trends of the top 4 populations with the most HIV diagnoses in Georgia, we can see that rates are only increasing among Hispanic and Latino males. Specifically, rates are actually increasing most among those ages 25 to 34, with male-to-male contact still being the most common HIV transmission category in Georgia. The disparities for these young Latinx individuals in Georgia, though, and all those really diagnosed within the Latinx community, unfortunately don't end with receiving a diagnosis of HIV. That's usually only the beginning, and getting linked to care and receiving care can be a monumental challenge. So, seems like a silly question, but why is receiving care so important? So linkage to care and receiving HIV medical care are vital parts of the HIV care continuum. This is a model that was initially coined by the Health Resources and Services Administration that is now widely used by clinics, health officials, policymakers, NGOs, CBOs as key benchmark indicators in the National HIV/AIDS Strategy for the United States. So this is done since we have significant data that supports that achieving all steps of the HIV care continuum leads to good health outcomes for patients and prevents further transmission. So the barriers to getting linked to care and receiving care for Latinx folks living with HIV are complex, and this slide by no means does the complexity justice, and I am not going to do this complexity justice because this is a national problem that is humongous, and there's a lot of players in this. But I'm going to break this down for the sake of this talk and to have a understanding of it. I'm breaking this down into individual or personal barriers felt or experienced by people living with HIV and macro barriers or societal larger scale barriers. So talking first about individual barriers. So the first individual barrier is stigma, which really needs no further explanation. If you are part of the Latinx community, as I am, you understand this deeply. So Latinx patients living with HIV face barriers to care due to concerns about what being in care will mean with regards to disclosure of their status and sexual identity to others. Is my mom going to find out when they send a letter to the house? Is she going to open it? Is my abuela going to pick up when they call by accident? Are they going to find out that I'm gay? How is my diagnosis going to affect my family and my partner? And this prevents people from getting into care. The second barrier is language. How do you navigate the complexity of this life-changing diagnoses and the behemoth that is the US healthcare system when you don't speak the language? It's overwhelming to just think about. Additionally, there's significant mistrust of the healthcare providers and interpreters, which can affect your desire to be seen. I can't tell you how many times I've heard from patients. I'm a native Spanish speaker. I obviously don't use an interpreter. How many times I've heard from Spanish speaking patients that they were in a conversation that involved an interpreter and the interpreter was not interpreting correctly what the physician was saying because they had a family member that also spoke English and said that doesn't make any sense. So October 1st just passed, which is National Latinx Physician Day. As rates of new HIV diagnoses go up in the Latinx community, as I've shared in the prior slides, there just aren't enough Latinx providers to care for this population. So less than 7% of physicians in the US identify as Latinx, despite Latinx individuals making up close to 20% of the US population. So there's implicit trust and comfort that comes with having a provider that speaks your language and understands your culture. I see this every day in my own practice. The third individual barrier is comorbid conditions. So what I mean by this is other health issues that affect your ability to access care. So the two that most affect the Latinx community are substance use disorder and mental health conditions. On a macro or societal level, the first barrier I wanted to highlight was lack of culturally appropriate services. This also encompasses the lack of Latinx providers, but it also takes the form of care that doesn't take into account the religious and spiritual beliefs of the Latinx community. There's rampant mistrust of the healthcare system within the Latinx community, and for those living with HIV, engaging in care may lead to fear of your clinic disclosing your immigration status to the government and risking deportation. So COVID-19 vaccines highlighted this, but there's also the significant fear of being the target of experimentation by the healthcare system. Are these medicines really going to help me or are they going to hurt me? Is the government putting something in these medicines to hurt me because I'm a minority? These are all things that during the COVID-19 pandemic that I, as an infectious disease provider, heard from a host of my patients. Lastly, but perhaps most importantly, the Latinx community remains the largest uninsured ethnic and racial group in the United States. And patients living with HIV may not be aware that, number one, there are federal programs that make care and medicines available to you either free or at low cost. And number two, that those programs do not require you to have an immigration status. So I'm obviously talking about the Ryan White program and the AIDS drug assistance program, of course. So I want to repeat that, and I think a lot of people on this call are aware of this, but these programs do not require you to have an immigration status to enroll, but I don't think that is common knowledge in our community. So let's shift a little bit to treatment 101. What I mean by this is just going through some of the questions that I engage with patients about with regards to treatment. So let's say a Latinx individual does get through the challenges of the US healthcare system and is engaged in care. They walk into my office here in Atlanta, we sit down without a translator, and we start discussing treatment options. So before we even talk about treatment options, though, we talk about the importance of treatment. And the first logical question all patients have is, when do I actually need to start treatment? And the short answer is right away. In fact, the answer is actually immediately, and often the same day that someone is diagnosed. So this is what's called rapid start. This wasn't always the case, though. And in fact, it wasn't until 2015 that the World Health Organization recommended starting treatment for all people living with HIV right away, regardless of CD4 count. Before, there were different markers of CD4 that you had to drop below before a provider would say, okay, it's time to start treatment. So this recommendation is especially critical for those diagnosed in pregnancy, as treatment reduces the risk of perinatal transmission of HIV to the unborn child. Lastly, we now have excellent data that supports that treatment and getting to an undetectable viral load, which means our laboratory tests can't detect the HIV virus in your body because the levels are so low that this leads to an untransmissible HIV virus. In other words, undetectable equals untransmissible, or U equals U. So treatment also reduces ongoing sexual transmission of HIV. The next logical question, the conversation that I have with patients when they first come into my office is, why is it important to adhere to treatment and what are the benefits? Can I just take this for like a month and be okay? Or do I really have to take this pill for the rest of my life? So this ties into the last slide a bit. But with adherence, you can have a sustained viral suppression. What this means is that you get to undetectable and you stay there. And this ultimately leads to decreased inflammation throughout the body and better health outcomes for patients down the line. There's also a reduced risk of drug resistance and the need to change medications in the future due to possibly building resistance. There's just also general overall better health as your immune system rebounds and gets to a relative normalcy along with a better quality of life. And the last benefit of staying on treatment and adhering to treatment, as I said in the previous slide, I'm going to say several times during this talk, is there is decreased risk of ongoing HIV transmission, which benefits the entire community. U equals U. So what are the first-line treatment options? I've been talking about treatment and alluding to treatment for the past 15 minutes. So what are they? As I mentioned before, you are often prescribed medicines and can pick it up immediately after your first visit with an HIV specialist, or that is really how things should be going. I can't say for sure that that's what's happening throughout the country, but that is the recommendation at this point for somebody who is newly diagnosed. And as I said, this can be on the same day you're diagnosed. You're diagnosed in the morning, you're seen by an HIV specialist in the afternoon, and by the time you leave that office, you have taken your first dose of your medication. For almost all of those that are newly diagnosed, and for almost all of those that are reestablishing in care, and what I mean by reestablishing in care is you were diagnosed 5 years ago, you maybe took medicines for a year, you haven't seen a provider in 2-3 years, you haven't been on medicines, but now you get reestablished with the clinic, you want to get back on medicines. And so for what are the options for folks that are newly diagnosed and those reestablishing in medicine? And the majority of these folks, the first line option is what we call a single tablet regimen. So this means that there are a combination of anywhere from 2 to 4 medicines in a single tablet that you take once a day. So in parentheses in this slide, you're going to see the word salad that you see are the commonly used abbreviations in the HIV world for the components of these tablets. And I just want to put them on here for your reference. So taking these single tablet regimens once a day can help you eventually become undetectable and can lead to all of the benefits we discussed in the first slide. So overwhelmingly, the most common first-line treatment option is Biktarvy. So there are a number of reasons for this, but I would say that the most important reason is that it is very well tolerated and the pill size is relatively small. I would say 75 to 80% of my patients are on Biktarvy at this point. So the majority of patients have no side effects. And for those that do, they tend to be really mild, primarily gastrointestinal, and resolve within 1 to 2 weeks. Now, is this everybody? Of course not. But I would say the greater majority of the patients that I see. So the option for Triamic or dolutegravir plus tenofovir alafetamide or tenofovir DF, and what I mean by dolutegravir, Descovy and Tivicay, more commonly known, When we give people the option for these two drugs, a lot of times it's because of insurance coverage reasons, and for some reason someone's insurance didn't cover Biktarvy, but they would cover Descovy and Tivicay. So the other option here, Triamic, is also technically a first-line treatment option as a single tablet regimen, but Triamic is a horse pill. It's huge. And it used to be the only recommended single tablet regimen for pregnant people starting treatment after some additional testing for some genetic markers. But that has now changed, and Biktarvy is actually on the list of recommendations. And so I think for the majority, most people that are going to be starting treatment now in pregnancy are going to be started on Biktarvy as opposed to Triamic. So the last option that you see here, Dovato, you'll notice just has two medicines, two of the abbreviations I talked about, as opposed to three. This is the only two-drug single tablet regimen that is recommended as a first-line treatment, but it is recommended only in special circumstances. So for many, many years, we thought that people living with HIV needed at least three medicines to suppress the virus. And it's really, I would say, over the last 5 to 10 years or so, we've had a number of studies that have proven that some people are actually okay with just two as opposed to three medicines to control the virus. And the benefit of two over three is essentially potentially less side effects. So you may say to me though, but Dr. Roque, what about the shot that I keep hearing about on TV? Because patients come in and they say, oh, I want the shot. So the shot, or in reality, two shots, is in reference to Cabenuva, which is the first long-acting injectable approved for HIV treatment. So Cabenuva is comprised of two medicines, cabotegravir and rilpivirine. And it's actually two shots, not one. So one shot for each of the medicines. It is given once a month for 2 months, and when you start the treatment, and then it's given every 2 months thereafter. So you get a shot today, you get a shot in a month, and then your subsequent shot is in 2 months and every 2 months thereafter. So there was a requirement when it was initially approved by the FDA for an oral lead-in, but that's not commonly done now. And I would say most people just go straight into the series of shots. So Cabenuva is not actually yet approved as a first-line treatment for those that are newly diagnosed. So it's not on that list that I shared in the previous slide. And it's not yet approved for pregnant or lactating people, but it is an option for patients that are reestablishing in care with a known HIV diagnosis. Cabenuva is not for everyone, though. Important contraindications, and this is what I talk to patients when they come in and they say, oh, I want the shot. Well, it's a great option, but it's not for everybody. There are certain medications, primarily seizure medications, that are contraindications for it. Having a history of liver disease, including hepatitis B, a history of prior resistance to certain classes of HIV medications. Those are all contraindications to it. There can also be pretty significant injection site reactions for patients. You get these two injections, you get them in sort of the fatty part of your butt. And primarily in the beginning, it can hurt. So if you're not someone that likes getting shots, this may not be the right option for you. And anecdotally, I can tell you that this on-site reaction when you first get these shots and this muscle soreness can actually be pretty debilitating for 1 to 2 days afterwards. It can feel, I have a lot of patients that work out quite a bit and can tell me that it feels like a really, really bad day at the gym and you feel like that for a couple of days afterwards. Similarly, if you travel for work a lot and can't be consistently available every 2 months during the period of time that you have to come get your shots, this isn't going to be the best option for you because you don't want to miss your shot because then you don't have any medicine in your system. This, however, has been a life-changing medication for patients, though, particularly those whose only medicine was taking their HIV tablet and felt significant stigma taking this tablet. I've gotten letters from patients saying, this shot saved my life because I felt so bad every time that I had to take this pill that reminded me of my HIV diagnosis that now I don't have to think about it. So overall, I think it's been a fantastic addition to our tool belt. The other medicine here that you see is called Simtuza, and it's actually another single tablet regimen, and I added it here for a reason. So we're not going to talk about it here, but a component of Cabenuva, cabotegravir, is now approved for pre-exposure prophylaxis. So if you've been on cabotegravir or Apretude for PrEP, the recommendation is that you be placed on either Simtuza as a single tablet regimen or its components as the first line treatment if you seroconvert and become HIV positive while on Apretude. So this is because there's a concern for resistance to some of the components of the most commonly prescribed HIV treatments, such as Biktarvy, since injectable PrEP with cabotegravir can stay in the body for a very, very long time. So Simtuza has a backbone medicine in it, a protease inhibitor that can overcome the potential resistance that you may develop if you seroconvert and become HIV positive while you're on Apretude. You can, though, be switched back to Biktarvy once more if that initial genotype testing that we get during your initial visit in clinic with an HIV specialist, if that doesn't actually show that resistance. So you're not going to be on Simtuza forever. You can actually go back to Biktarvy if that genotype testing shows that things are okay. At this point, though, you may come back to me and say, Dr. Roque, that's not the shot that I meant. What about the other shot? And not talking about Cabenuva, but the other one that's been in the news recently. So you're probably in that situation talking about Sunlenca or lenacapavir. And I'll just refer to this as lenacapavir ongoing simply because Sunlenca just doesn't roll off the tongue for me. So it was in the news during the summer because the results of a fairly large study were announced that showed that lenacapavir administered twice a year via an injection to cisgender women and girls in South Africa and Uganda offered 100% protection against HIV. You heard that right, 100% protection. So less than a month ago, the results from a partner study to the one in cisgender women, this time in cisgender men, transgender women, and gender non-binary individuals who have sex with partners assigned male at birth in various places across the world showed close to the same results. I believe it was like 99.7% effective at preventing HIV. So this news understandably shook the HIV research world. Just last week, actually, Gilead signed an agreement, that will allow a generic version of lenacapavir to be made available in 120 low and middle income countries. But unfortunately, a lot of these countries leave out Latin America. So there's still significant work that needs to be done there to bridge the accessibility gap for Latinx folks, not just in the US, but around the world. What I just mentioned, though, is lenacapavir for PrEP. So what about lenacapavir for treatment? So currently, lenacapavir is FDA approved as a twice yearly injectable treatment for people living with multi-drug resistant HIV. So this means that the folks that aren't candidates for the treatment we've already discussed because they have significant resistance, or in essence, their virus just doesn't respond to the conventional treatments that we have available anymore. So most patients needing lenacapavir have actually exhausted all or close to all the options that we currently have available for treatment. Lenacapavir is given in combination with what is called an optimized background regimen, which essentially means these patients would take whatever their virus is still susceptible to orally, in addition to the lenacapavir injections. This has been a life-saving treatment for a number of folks that otherwise would have essentially no available options by mouth or injectable. However, it's still really, really hard to get approved by insurance companies, including federal insurance providers such as Medicaid and Medicare. And I'm actually in the process right now of applying to Georgia Medicaid for one of my patients for this medication. It's the first one that I've applied for. And it's taken an unmentionable amount of manpower, and many folks in my clinic are involved. So the barriers to get this medication still have to be lowered quite significantly. So it's available to those in the community, and not just in our community, but for all people living with HIV that truly need it. So we're close to the 30-minute mark, and I want to end by going back to where we started. So how do we reduce barriers to care for the Latinx community so that, number one, we've reduced the number of members of our community that are diagnosed with HIV, and number two, so that if they are diagnosed, they can get into care and get to undetectable, because as I've said several times, undetectable equals untransmissible. So the first step is to prioritize PrEP. So that's the bottom line. And my colleague at Emory, Valeria Cantos, has spent her entire career working on this issue. Now, I'll actually be working with her on a forthcoming project about increasing access to long-acting injectable PrEP with cabotegravir at federally qualified health centers here in the Atlanta area that primarily care for Latinx folks. But increasing PrEP access is the first step, as this is the crucial component to reducing new HIV diagnoses. The second step is enhancing treatment accessibility. So this simply means meeting people where they're at. This means starting after hours clinics so that people don't have to take off work. This means virtual visits. This means mobile clinics. This means having clinics at frequently visited centers, such as embassies. This means staff that speak Spanish, starting from the receptionist at the front to the healthcare provider to the social worker. The third step means to target behavioral intervention. So this can mean a multitude of things. It can mean more community organizers that help link people to care. It can mean dedicated clinic staff reminding people to adhere to their medication in their language, not using a translator. It can mean an emphasis on addiction treatment and mental health treatment, so people can stay engaged in care. And it has the capacity to mean so much more, but ultimately the goal is to have people continually engaged in care. And then the last and perhaps the most important step to recognize is that our community is diverse, and having people in power recognize the diversity of our community is crucial to this process. I interpret this to mean that federal leaders need to collaborate with community leaders to figure out the best interventions for our community. They need to understand that what works in New York doesn't work in Miami, and may certainly not work here in Georgia. That we are a vibrant community, but very diverse, with different customs, different foods, different experiences. Federal leaders need to understand that we are not a monolithic group and that one size does not fit all for the Latino community. So I wanted to give a big thank you to the Latino Commission on AIDS, and especially to Luis for inviting me, and to my friend and mentor, Dr. Valeria Cantos, for graciously putting up my name for this talk. And this is my little Cubanita looking at a chicken empanada like it's the most beautiful thing in the world. She reminds me that our community is worth fighting for every day. So please contact me on my email with any questions, but I'm also happy to answer any questions that may come up.
Thank you very much, Dr. Roque, for this amazing presentation. Actually, a lot of information we received today, a lot of updates for myself. Like I'm learning here too. So I saw you mentioned Dr. Cantos. I know her. Actually, we used to work together during the pandemic, the COVID-19 pandemic, bringing information to the community about vaccines. It was very nice meeting her. And also, you put a slide with from Vincent Hilado Ramos, who is a member of the board of the Latino Commission on AIDS for years. So I'm happy to hear the connection between NLAAD, Latino Commission on AIDS, and you at Emory University. So I think there are some questions in the Q&A answers, Q&A answers box. Let's check. So Brenda Cruz Scott, she asked, could you please repeat the percentage of Latinx medical providers in the U.S.?
Yes, so the data that I presented was actually about physicians in the U.S., and it's less than 7%. It's actually close to 6%. And for the National Latino Physician Day, the tagline was 6% is not enough, essentially, because we will be close. We're now 20% of the population, and we're going to be close to even more as the next decade rolls around, and there's just not enough of us.
Yeah, it's very important that these professions are more promoted among Latinos. I mean, I know it's very hard for many Latinos to be able to pay medical school, but there should be ways to increase the number of doctors, physician assistants, nurse practitioners, nurses, social workers, everything to provide services to Latinos. So another question is it up to providers, if it is up to providers and CBO staff to spread the word on ADAPs in the US? Also, perhaps the working in non-traditional events could help spread information to people who are not engaged in care. That's a comment, I think. Yeah, yes, also, we need to understand that ADAP is not the same in every state. Every state has different rules and regulations for ADAP. Like if you come to New York, you will receive everything for HIV treatment and care and services. If you go to other states like Alabama or Wyoming,
Mhm.
you might not receive anything. So you have
Yeah,
to be careful where you are and work together with your doctor and the people that is helping you, health workers and people from the CBOs. They will tell you what to do in each state.
yeah. But I will say now shifting from where I trained in San Francisco, where there are a lot of different programs, to now in Georgia, I think what I would say is that there's always, even if you're in a state where ADAP may not be as friendly to folks that don't have an immigration status, you'll always find there's always going to be a way for you to get care. Don't despair. Talk to your healthcare providers and to the people in your clinic.
That's true. I also want to ask here, like, one of the barriers that you mentioned is very important. It's the lack of medical insurance for our Latinos, and we immediately think about immigration, right? We think that most of us are here immigrants, and at the beginning we don't have access to different things. But part of the commission is doing some reports on Latinos in different states, especially in Texas. They started with Texas, and they found out that in several counties where the Latinos are not just arrived to the state, they are second or third generation Latinos and they speak English and they still don't have medical insurance. So there is a disconnection here between what Latinos have availability, resources available for them, and they're American. They were born here. They speak English. They understand everything, but they still don't get medical insurance that they should.
Right.
So
Yeah.
there's also
Yeah.
that point that we need education to even Latinos are here born in the states, second, third, fourth generation.
Yeah. One size does not fit all for us.
Yeah.
We cannot make one policy that's going to affect everybody.
Exactly. So there's another question. A person that is HIV positive and their strength changes, does that mean that they need to take more than three medications?
So I'm not sure what they mean by strains change. Sorry, somebody keeps texting me. I
Mutations, I guess.
apologize. Um, so it may be, and so it may be that that person, depending on what their level of resistance is and how many resistance mutation they've accumulated, they may need to take three or more meds. And the person, for example, I'll give you the example of the patient that I'm applying for lenacapavir for now. So he was on three different medicines and has now developed resistance to one of those, which leads them to just not sufficient medicines at this point. And so, so yeah, I certainly have patients that are not on those single tablet regimens. I think the majority of patients are, but not everybody.
Thank you. Do most insurances cover the cost of these medications?
I would say, in my experience here in Georgia, most of them do. I will say that not everybody covers what I would consider to be first line medicine. So randomly, some insurances won't cover Biktarvy for some reason, even though it's the most commonly prescribed medication. But it kind of depends on the tier of insurance. I would say globally, though, most insurance companies will.
Does some sort of law regulates what the insurances, medical insurances companies cover? I mean, I don't, who regulates that?
Well, that's a great question that maybe even above my pay grade. But I think that most insurance companies have their preferred medicines, and so that's based on the ones that aren't generic yet. That's based on kind of the agreements that they make with the particular drug companies.
So does it mean that if I'm having certain insurance, like I don't want to mention a name, it's like X like insurance. So do I depend on what they approve to take my
Hmm.
medication? Oh,
It a lot of times it does, but I would say overwhelmingly over 75% of patients that have private insurance, Biktarvy is going to get approved. And then Medicare, which a lot of patients have, and Medicaid, Biktarvy is approved.
Okay. And so
And I keep mentioning Biktarvy just because of like it's such a common medication that we
I'm
prescribe.
taking sorry.
Yeah.
So, do you consider Delstrigo as valid treatment option for Latinx community?
I would say Delstrigo is a valid treatment option, but I would say Delstrigo has a very low barrier to resistance. What I mean by that is that it's one of those things where if the patient isn't taking it 100% of the time and maybe they miss one dose a week or two doses a week, they could develop resistance really quickly to Delstrigo. And so it's not something that we use super commonly now, just because we have medicines that are better tolerated and have higher barriers to resistance, just in case you forget your medicine every so often.
Behavioral interventions are no longer a priority. Biomedical has taken over. How do you go back to update behavioral interventions?
Uh, how do you go back and update behavioral intervention? I think that's actually a great question. And I would say that a lot of times, unfortunately, this is dependent on funding. And this is dependent on the funding and the people that you can hire to carry on those behavioral interventions. Because if you don't have the funding to hire those people that are doing the calls that aren't necessarily nurses or MAs, but are integral parts of your team to keep people up to date on their adherence. And if you don't have the funding to do that, then it's really hard because that means that people that have already 9 or 10 jobs are also doing that job, or the physician is doing that after hours and such. And there's only so much you can do. And so I think more money allocated to this is the way that we increase the emphasis on behavioral interventions.
Yeah, and I should say, like most of the people who attend this webinars are people that works in CBOs and
Mm-hmm.
organizations. And what we do as a commission is that we do advocate also. We advocate for funding. We advocate for programs that are providing services to Latinos in New York and in also the rest of the country. We actually, if you don't, whoever's attending the 2 days webinar, you can go to our website, latinoace.org, and you can check what we're doing, and you can join us in different things that we're doing on the national level. And you apply those things that we're doing in your local government, state or county or uh, region where you live and you work. Um, Talk more on Cabenuva as prep, just as somebody.
Oh, that's a separate talk. We're gonna have to invite me back for that. Because that's a talk in itself. And I don't know exactly what they want to hear. I think the main point is that it's not as readily available as we would all love. And I think the takeaway from the national data that we have is that the uptake of Apretude or cabotegravir for PrEP, which is half of Cabenuva, hasn't been as good as we would like. And part of that is because getting Apretude is challenging, and not all insurances are covering it because you have a reasonable alternative in Truvada. And so a lot of insurance companies are like, sorry, we're not going to cover it. There are programs. Drug companies have programs where you can get patients on them if they're underinsured or if their insurance company says no. But I would say it's taken a lot of manpower for clinics like my clinic, to institute this, and it just has not been as seamless as we hoped. But that is a whole different talk, actually.
So it comes again to the point that insurance companies are dictating what we're taking, either for treatment or prevention as well.
Yes, yes. Insurance company, drug companies, yes.
Well, Elena Quiles says great info, Dr. Roque, and Brenda Cruz says thank you very much. Norma Cordero says, it's not a question, but can you share your slides?
Sure, I can send them to Luis, and you can have them.
Yes. Dovato is recommended in what cases?
So Dovato, there are some caveats. I didn't go too much into this because I didn't want to go too deep into the pathophysiology, but Dovato is recommended if your initial viral load is under a certain amount and if you are not co-infected with hepatitis B. And so a lot of times we don't know when someone's walking to the office and it's a new diagnosis. They get their labs. We don't know from those labs until later what those initial values are. So Dovato is not one that we generally give people right off the bat. Unless we have that data from maybe they went and got tested somewhere else and they already have labs with them. But those are the caveats essentially. Like not everybody is going to be a candidate because it depends on what your initial values are, and it also depends on whether you are co-infected with hepatitis B.
Very good presentation, easy to understand, and proposes the issues and possible solutions.
Thank you.
Um, are you aware of all the states have a program alongside ADAP that pays for health insurance premiums, like the one in New York State or APIC? Mhm. I think in New York State, the one that pays for everything is ADAP. And Medicaid, actually, Medicaid covers more than anything, cares for HIV. But for people who doesn't have Medicaid or any other insurance, we use ADAP in New York.
Sorry, Louis, say that one more time. My internet sort of cut off for a sec.
Yeah, no, the question says, are you aware of all the states have a program alongside ADAP that pays for health insurance premium, like the one in New York State or APIC?
So I can tell you what is available in Georgia, which is HICP. And so I don't know outside of California and Georgia, really, because those are the states where I've practiced. But I would say even here in the Southeast, where sometimes the politics are challenging and there's not as much support, there's a program that pays for health insurance payments.
Yes, every state have insurance,
Yeah,
but that state may use funds from RNY for cover those
yeah,
programs. That's why ADAP is part of it.
yeah,
So in New
yeah.
York, actually, ADAP is APIC is ADAP, and that's New York. So that's same as you. I know for New York. And can you give examples of types of harm reduction you may conduct for people living with HIV who absolutely are hard to adhere to medications?
Yes, so we actually in our clinic we have a nurse who part of her job description is essentially is to be the adherence nurse, and so she does frequent calls to patients that are not suppressed, so patients that are not undetectable, so not the case studies that I talked about in the talk, and she does so every so often and has a good relationship with all these folks, and essentially tries to work through a decision tree as to what are the barriers that they have. Is it remembering to take their medications? Could we help with alarms, with pill boxes? Do they need to be called more often? Do they need to have a family member who's aware of their status involved so that that family member can remind them to take their meds? And it's really about trying to get to the root of why they're having issues with adherence and trying to work through those problems. But I would say most clinics have a whole set of staff that are dedicated to helping patients.
Any other question for Dr. Next Rocky Corner? There's some more questions. Before ending, I wanted to invite those who live or are in New York City. Tomorrow we have the NLAAD press conference. Oh, there's more questions. Let me see. What percentage of the patients of your clinic are over 50 and are
Oh,
that?
that is a great question. So, as I'm sure a lot of folks on this call know, we have an aging population of people living with HIV, as we have long-term survivors now, and folks that are being diagnosed after the age of 50. Ooh, I would say maybe 30% of the patients in my clinic are over the age of 50. I'm ballparking that number. We have two, I would say we have two demographics. We have really young patients, and then we have patients that are over the age of 50 and over the age of 60. Less so, I would say, in the middle. Like I have 18-year-olds and I have 82-year-olds. And so it's a very large discrepancy there. And what geriatric screenings are done, I would say probably not enough geriatric screenings because I'm not a trained geriatrician. And so as people start to have more comorbidities, as they start to develop more health problems outside of their HIV, because a lot of times for these folks that have been living with HIV for 15, 20, 30 years, sometimes longer than I've been alive, to be honest, the issue that we talk about is not their HIV. They're stable in their HIV. They're taking the recovery. They're fine. It's these other health issues. And a lot of times it does get to be a lot. And so we need the help of a multidisciplinary team. And that's when I can refer them to a geriatrician to help with that.
Okay, thank you for that. Yeah, definitely. I mean, people with HIV is even longer years. I mean, than in the past, and those in the past we didn't know what people with HIV would have when they were old because we didn't reach that age. And now we're doing like everybody else, from the cancer,
Absolutely.
hepatitis, hypertension, heart conditions.
Heart disease and diabetes.
Yeah,
That's what I worry about now.
yeah. Okay. And so, any other? And yes, thank you, Dr. Roque. Very important information educating the risk. Thank you very much.
My
So
pleasure.
before,
And I'll send Luis my presentation and that can be
perfect. Yes, I
disseminated,
will
no
share it
issues.
to all those who attend today. You receive an email with the presentation. So before ending, I want to invite those who live in New York or in New York City. Tomorrow we have the NLAAD 2024 press conference at 10 in the morning in the New York City ASA Memorial. It's located on in front of what used to be St. Vincent's Hospital in St. Vincent's Triangle. So if you like to join us, please 10 in the morning. We will have a press conference. Councilman Eric Butcher, representative from the New York City Department of Health, will be present and share some remarks there. Also, people from staff and other CPLs. To remind you also, we have tomorrow in the afternoon another webinar. It's basically about HIV and aging. It's going to be presented by one of the members of the staff of the Epidemic Commission on AIDS from the Department of Research and Innovation. And the last webinar will be the following day in the morning with ACEView, who are also going to present about the HIV care cascade, which is all very important in terms of having talked today by Dr. Garner, Dr. Roque, sorry. So I also would like to remind you, all of you who have worked in CPL and nonprofit organizations that used to be part of NLAAD with events. I know after COVID-19, things changed and everything went virtual and we were not able to meet. And so many of the events disappeared. And so we're trying to get them back. As you can see in the presentation that we have today and previous presentations, testing is still important. We need to identify those who live with HIV without knowing it, to reduce the risk of transmission and also to improve the health of these people. So if you are available and you can have events, maybe not this year, maybe next year, join us again and doing your events. And if you cannot do testing, you can also promote the gay people on those events, whether they are virtual or in person. So I suggest or ask you to join us the campaign with events like you saw in the past. And with that, I think I'm going to join Kate Burris and Jonathan Alejandro saying thank you very much, doctor, for your information. It was an amazing informative piece of HIV and treatment. And I'm pretty sure you'll hear from me again for future events. Thank you so much. And thank you, everybody,
Thank
for
you.
being here today.